what we've got now is we've got a talk from Ola Niewiadomski, who is a gastroenterologist and endoscopist who works in Melbourne. And of course, living in Melbourne, she has not been able to come here. So we've got a virtual presentation that she's going to give.
Good morning, everybody. It's a pity I'm not able to be there with you today. I had been looking forward to the trip to Auckland, but it's good that we're still able to do this in some fashion, and hopefully I'll be available to answer your questions at the end of your presentation. So my name is Ola Niewiadomski. I'm a gastroenterologist and endoscopist in Melbourne, and I have an interest in amyloid in the gastrointestinal tract. Today I've been asked to speak on this topic to you. So as you're all probably already aware, amyloidosis is a disease that comes about from the misfolding or abnormal folding of normal proteins found in the body. And they then take on this new shape, as illustrated here in the bottom on the image. These misfolded proteins can then deposit it anywhere in the body, and that can include the gastrointestinal tract. It can also affect the liver, and it can affect the vessels or nerves supplying the gastrointestinal tract. And any of these, this process of deposition in this area can then lead to abnormal function in the GI tract. So when I refer to the gastrointestinal tract, I'm referring to anywhere from the tongue, or including the esophagus, the stomach, into the small bowel, of which on an average human is about 3 to 4 meters of, and then the large bowel, all the way through to the anus. And amyloidosis is a disease that can in fact affect any part of the GI tract. So I'd just like to spend a couple of minutes looking at the anatomy of the gut in a bit more detail. This is a cross-sectional view of the bowel. It is very similar really between the small bowel and the large bowel. The thick tube in the middle, and with the opening in the middle there is the mucosal layer where the food goes through and is absorbed, and is then propelled through to the large bowel, where in the large bowel the mucosal layer its main function is absorption of water. And so that's one component of the bowel. You have this mucosal layer. Surrounding that, there are deeper layers with various lymphatic tissues in there, also nerve endings and muscles, and the muscles help propel whatever's in the bowel forward. Importantly, we can also see in yellow are nerve endings. We can have it's normal to have inhibitory or excitatory nerve endings supply the bowel, and they all have a different function. So you can see if someone, for example, in someone the amyloidosis has deposited in excitatory nerve endings, that means there's less stimulus to propel the bowel. That person will suffer from constipation, poor motility issues. Whereas if someone has the reverse affecting nerve endings really that are more inhibitory, that patient may have rapid transit of the bowel. And amyloidosis is one of those conditions that can affect any of those structures, even within the same type of amyloidosis. There do tend to be patterns to it, and I'll go into that in a little bit more detail, but ultimately the symptoms can really vary in patients, even with the same types, and patients can present with a whole lot of different symptoms. So as I alluded to on the previous page, already it can be challenging to diagnose patients who have amyloidosis of the GI tract, especially if that's the initial index presentation with GI symptoms. Added on to that is that it's quite an uncommon condition for a gastroenterologist to come across in general. These images are just here really to illustrate how it can really, even within the same type of amyloidosis, looking inside the bowel, have quite a different appearance. So looking first in the top left-hand corner, we can see that it's affecting more superficial vessels in those sort of underlying mucosal layers. And this patient may present with bleeding or iron deficiency anemia. Next to that is an image of the stomach. And with a big ulcer there, and that can present with AL amyloidosis or AA occasionally, and that can present again with subtle bleeding or more significant bleeding, but also impact emptying of the stomach because of the size of it and the inflammation associated with it. On the bottom we can see a large bowel, and here the changes are really quite subtle with just a little bit of edema and inflammation, but in fact this may be affecting the mucosal function of the bowel quite significantly, resulting in quite profound diarrhea. Whereas on the bottom right hand corner there in the large bowel, again this is something found more in AL amyloidosis, there's these submucosal deposits and formation of masses that, if there's enough of, can impact motility. So keeping all of that in mind, we'll move and spend the rest of the talk now really focusing on the different treatments in amyloidosis. Now the treatment of systemic amyloidosis in general will usually result in stabilisation or even regression of GI amyloid and therefore improve symptoms. But I'm not going to talk about that aspect of it. I'm going to be focusing now mainly on managing the gastrointestinal symptoms specifically. But what are those symptoms? Well, the most common gastrointestinal symptoms in amyloidosis includes weight loss, diarrhea, abdominal pain, constipation. There can be problems with generalized motility, which can present with heartburn, where the stomach's not emptying properly, so that would be nausea, early fullness and bloating, loss of appetite. And less frequently, there's the presentation of acute gastrointestinal bleeding, whether that's fresh blood or dark black blood as it's passed through the GI tract. Fatigue can be multifactorial but can be due to malabsorption and malnutrition. Now this slide is looking at the different symptom patterns or which symptoms are more likely to occur in the different types of amyloidosis. I'll just go over this briefly. The main aim is really to point out there is quite a bit of overlap between the different types, but there are certain things seen in one type more than the other. In AL amyloidosis, weight loss, diarrhea, gastric emptying problems, or heartburn, nausea, vomiting are a problem. These patients can also present with abdominal pain either due to constipation or they are slightly more at risk of this pseudo-obstruction or obstruction because of the potential to cause abnormal deposits in the bowel wall. Bleeding can also occur. In hereditary amyloidosis, the more common symptoms are weight loss, diarrhea, again the gastric emptying problems and heartburn and constipation. Just touching briefly on AA amyloidosis, this is much less common and it tends to cause this infiltration directly onto the gut mucosa, which can have those subtle features I showed you on those endoscopic images. These patients will present with weight loss. They're more likely to present with bleeding and can also get abdominal pain from obstruction. These patients can also present with protein losing enteropathy, which still overall is quite an uncommon presentation. It's a very typical clinical presentation of not only profound diarrhea and malnutrition in certain vitamins, in particular fat-soluble vitamins, also presents with significant leg swelling and fluid around the abdomen or lungs. So looking at some of these motility problems and focusing initially really by structure, so when it comes to motility. So firstly the esophagus, which is where the food goes down into the stomach. The typical symptoms if there's a problem with the esophagus is heartburn, so acid coming up, discomfort, chest pain, and also difficulty swallowing if the muscle layers are affected, so food sticking or needing to drink a lot of water. The treatment here is trying to optimize everything else, so reducing acid in the stomach by proton pump inhibitor or adding on another tablet called the H2 antagonist to really diminish any sort of reflux disease. Also, lifestyle measures can be quite helpful in the heartburn and difficulty of swallowing, and that's having small frequent meals, not overloading the stomach, bed elevation at night, not pillows, but the whole bed being lifted up on a little bit of an angle to prevent the gravity impacting the heartburn, and also avoiding late, large meals into the night time. The The motility issue, so the difficulty with the foods getting stuck, is trickier to manage. On occasion, your doctor may prescribe a calcium channel inhibitor to try and relax some of those muscles, but it's unclear how effective that is in amyloidosis. Motility problems are common involving the stomach, and that means that the stomach most frequently is not emptying as well as it should. So that's called either gastroparesis, or if there's a mass from the amyloid in the stomach stopping the food moving along, it's more of a gastric outlet obstruction. And you may feel early fullness, have a lack of appetite, get full with only a few bites, have nausea, and as it progresses, or in more severe cases, vomiting as well. Again, the lifestyle changes that are important, having small, frequent meals up to 5 meals per day, avoiding high-fat foods because they will sit in the stomach naturally for longer, having higher protein meals, but also having some fibre, but really trying to cut down on the insoluble fibres such as nuts, beans and grains, because again they tend to sit in the stomach more. Because having regular meals, if the symptoms are quite severe, can be problematic, it's okay to actually move to more fluid diets and only eating for enjoyment, the small amounts for taste, but supplementing each meal with various supplements. And this can be quite beneficial because the liquid will naturally move through the stomach quicker. Medications in this area are also very helpful, so I'll go over these in a little bit more detail. So domperidone or Motilium is a tablet that's used to try and empty out the stomach. We can use quite high doses of this, up to 4 times a day. I usually recommend using this half an hour before each meal and also before going to sleep. And so that will help empty out the stomach overnight. It can relieve the nausea, it can improve the appetite, and can stop vomiting. It's generally pretty well tolerated. A very small percent of people have an increased prolactin level from use of that. I may notice some breast tenderness, but realistically that's quite uncommon. There has been in the past concerns about these cardiac arrhythmias in patients on high doses, but in fact there has been a relatively new study showing that even in patients, and so a lot of patients would have an ECG at the baseline just to make sure they don't already have, we look at what's called the QT interval, make sure naturally someone doesn't already have a prolonged QT interval. But a reasonably recent study has shown that even in those patients, or patients who, when they go onto the medications, only about 6% have any prolongation, and it didn't actually seem to increase the risk of cardiac arrhythmias in that study of over 200 patients. So what that means is that I do feel more comfortable pushing up to about 80 milligrams of that medication if there per day, if there is benefit to the patient. The new medication that is available in Australia, it's TGA approved, but it's not on the PBS, meaning there is an out-of-pocket fee. I wasn't able to find what that's like with New Zealand, if that's available to you at a subsidised cost. And possibly there's something up for discussion at question time after this. But this medication, known as Procalipride, with the drug name as Resitrans, has been shown to excite the little neurotransmitters in the muscle walls of the bowel and help propel the bowel. And so its first line of treatment was for constipation, but in fact in recent years it's also been shown to help with motility in the stomach. And there have been a number of studies now that show that it helps to empty the stomach, and there have been benefits in nausea, bloating, and that sensation of fullness. It's still unclear how hard we should push this dose, pending sort of further studies on this when addressing the gastroparesis or the problems with emptying the stomach specifically. But definitely doses of 2 to 4 milligrams per day have been shown to help. The side effects tend to be mild, but can include headache, diarrhea, or abdominal cramping. In Australia, patients out of pocket at $70 a month, roughly, if they are on 1 tablet a day. But occasionally, as symptoms settle, I have been able to wean people to 1 tablet every 2 days. I'm not sure what the cost is in New Zealand. And then the others, occasionally pharmacies and public health, public hospitals will subsidise this cost. Nontriptyline is an old-fashioned antidepressant at higher doses, but it has been quite useful in the use for abdominal pain for a whole wide range of reasons, but also has shown some benefit in this problem of nausea and vomiting, gastric emptying problems. Again, it can cause side effects, but because we're using low doses, those side effects are much less likely. Occasionally, patients with amyloidosis will require rescue therapy, meaning despite highest doses of those medications and all the lifestyle modifications, the stomach is just not emptying because of the degree of the amyloid deposition, or because there is, especially with AL amyloidosis, a lot of infiltration of the normal stomach wall, and really that's highly impacting the ability to empty the stomach effectively. The first-line rescue therapy is admission at home would be a pure liquid diet for 2 to 3 days at a time, using ondansetron along with that, but then being mindful of the a dose of the other prokinetics that were being used, and also potentially using an oral erythromycin as a salvage therapy. If that's still not enough, then admission to hospital may be required for IV hydration, and then using IV intravenous erythromycin, which is an antibiotic, but it has this it has an effect on some of the motility receptors that can be very good at emptying the stomach as a side benefit to this antibiotic. And usually, depending where the patient is in terms of the amyloidosis journey, settling symptoms over about a week period with these strategies may be effective enough to be able to go home. The problem with the antibiotic, it's not a long-term action, it doesn't have long-term benefit because it tends to, there's a fatiguing response, it tends to be less effective after about 4 weeks. In even more severe cases, sometimes a degree of enteral tube or enteral feeds, which means tube feeding is required, and that means basically bypassing the stomach and using liquid supplements straight into the jejunum. Now that can be done in a short-term basis, as you can see here in this illustration in the bottom, where the tube is inserted through the nose, either through endoscopy, gastroscopy, or in the X-ray department, and then it's lodged into the small bowel, and then the patient is fed completely just through there, and you don't get the nausea, vomiting, or anything because a lot of that's coming from the stomach. Long-term, and this is quite unusual to need, especially if there's ongoing treatment for amyloidosis in general, but it is also used in other gastrointestinal problems, is this permanent tube when then it's inserted through the skin into the small bowel, and then either all feeds or 50% of the feeds are put in through this tube here. But this is really only used or suggested for conditions that are thought to be irreversible, and therefore in amyloidosis I'm not aware of it being used quite frequently. So moving now on to the other motility problems of constipation. In terms of lifestyle modifications, first few things to do: fibre 30 to 40 grams a day, no point going much higher because it causes bloating and distension. Adequate water intake. Adequate physical activity. This is a common problem for patients diagnosed with amyloidosis or any severe disease, either where the physical activity reduces significantly, but that is a trigger for colonic motility, as are regular meals a day, even if they are small. That is quite important to adhere to, because that's a natural physiological stimulus for the colon to propel the stool along. Now, in terms of beyond lifestyle management, I then use a baseline stimulant and bulking agent. So that can be psyllium, or in fact flow, which is something that's been designed in New Zealand, is a kiwi extract that does the same thing and also has a probiotic along with it. So that's sort of like the baseline that would be used every single day. On its own, the benefit of that is minimal, but that forms sort of the basis of then adding on an osmotic laxative, so it would be that Movic or Osmolax, and also on top of that a stimulant laxative. which can be bisacural or some of the other traditional ones, or Procalipride is very effective in this space as well. So then moving on to the management of diarrhea. Diarrhea is a little bit different in the approach. The first thing that can be useful is to try and determine what the underlying mechanism is of the diarrhea, because that can help tailor the most appropriate treatment. One of the causes is something known as rapid transit due to autonomic neuropathy. So what that basically refers to is, as you would remember, I showed you the picture of the nerve endings going into the gut wall. Some of those nerve endings in their normal function stimulate the bowel, and some of them actually stop the bowel from working too fast. So it's the balance of both of those that helps maintain good bowel function. And so if the nerve endings that are meant to slow down the gut have been affected by the amyloidosis, that can present with a rapid transit. In terms of managing that, we then manage with medications to do the reverse and slow things down. Other causes may be direct damage to the mucosal layers, especially in AA amyloidosis, but also in AL. And so in these patients, sometimes if someone's developed gastrointestinal manifestations, in particular diarrhea, during the course of the amyloidosis, a gastroscopy and colonoscopy can be helpful to document degree of damage to the mucosal layer and ulceration, to have an idea why, what's behind the diarrhea in that case. Fecal calprotectin is a non-invasive marker which wouldn't really, that can be basically used to track that sort of inflammation and give some additional information on that. Small bowel bacterial overgrowth is something I consider in patients who present with diarrhea and quite extensive bloating or distension. That usually is marked in these patients, and treatment can then be tailored down the relevant antibiotic pathway. I've again mentioned protein losing enteropathy. There are quite clear clinical presentation features and also tests that can be done, but ultimately that still remains a relatively uncommon cause of diarrhea and amyloid. Frequently though, in diarrhea it may be a combination of one or two factors at least. So the standard approach to anyone with diarrhea is to slow down the gut, and that can be done with something like gastrostop or loperamide. The key there is not to be shy about it and to keep pushing up the dose, because ultimately it's well tolerated, and you can use doses of 18, 20 milligrams per day, and in some small bowel, in short gut syndrome patients, we use even higher doses than that. Codeine can also slow down the gut, but it can sedate you. It has a sedation effect. There is some evidence for the use of what are called bile acid sequestrants, so cholestyramine. Initially, the studies showed that in patients with ATTR, there's potentially this process of bile acid malabsorption, and so any excess bile acid that's not reabsorbed in the small bowel, as it should be as part of its normal process, hits the large bowel and irritates the colon. And so we get these sequestrant sachets or cholestyramine sachets that are taken 2 to 3 sachets per day, and it binds up some of that bile acid. It needs to be taken at other times to other medications, and it can be a bit gritty to drink in, so dissolving it in juice can help. The key again there is not to just try 1 sachet per day, but up to 2 or 3. And even though most of the evidence initially came from ATTR, it is a useful tool to use if some of the other strategies are not working. The important thing to consider with diarrhea is the patient malnourished, and that's really with your doctor looking for some of the blood test results there, and oral and IV supplementation. Small bowel bacterial overgrowth is not an uncommon cause, and I won't go into why that is in detail, but it can be due to motility, can be due to medications, can be due to the amyloidosis itself depositing in the bowel. Basically what it presents is with bloating and chronic watery diarrhea. Flatulence can be a problem with this, and it's basically due to too much anaerobic and aerobic bacteria found in the small bowel that usually should live or reside in the colon. It is diagnosed with a special breath test, and There are a few things around that, in that you can't be on, there are a few quite strict rules around how to test for that in terms of being on acid suppression. But what it shows you here, I find it useful to show you this. On the left-hand side there, we can see some of the small bacterial overgrowth. And what happens is that the bacteria found in the small bowel will digest this lactulose and produce hydrogen, which get absorbed into the bowel, into the bloodstream quickly, and is expelled in the breath test of the patient who's doing the test. And we see this early sudden rise in the hydrogen production as compared to someone who doesn't have excess small bowel bacteria. There are some limitations in this study, and it's not either, it's about 70 to 80% sensitive and specific, and so we just need to keep that in mind. If the breath test doesn't fit with the clinical picture, sometimes it's useful to treat if there are predisposing conditions thought to be associated with this small bacterial overgrowth, and if there's clinical symptoms look very consistent with it. The new changes in treating of this condition is that there is now rifaximin, which is a non-absorbable antibiotic that can be taken 3 times a day for 2 weeks. This is a new medication. It's used on label for other indications. It's also not available through the PBS in Australia, so again, it's at a cost, but that cost is subsidised by the gastroenterology units at the public hospitals, privately sort of looking at about $60 or $70 a cycle, done through a compounding pharmacy. The more traditional antibiotics were things like ciprofloxacin, Bactrim, Flagyl, and Augmentin, though I've kind of gone out of favour with Augmentin because it is more, it does increase the risk of certain infections in the gut, like Clostridium difficile. And look, the majority, about 50% of patients have a good sustained response after 1 cycle, but some patients need recurrent cycles. And really, if there's no benefit within that first course, the indication is then to change to another antibiotic. Again, there can be treatment-resistant or severe medically refractory diarrhea. In those situations, patients usually present to hospital. There is some evidence for the use of something called octreotide. That's it's a medication that reduces some of the gut and other pancreatic hormones that all impact on the motility of this bowel. So it reduces the motility of the bowel, and it also stops these sort of leaky vascular membranes. And through all of that, it's been shown to slow down the gut and be useful in refractory diarrhea. It can be given as an intravenous infusion or an injection. And again, in Australia it's not on the PBS for this indication, but in conditions such as amyloidosis, because of the rarity and things like that, sometimes it's possible for the hospital to subsidise it. This is very costly. If someone ends up requiring this for a prolonged period of time, you're looking at about $1,500 a month. So I've spent a bit of time on the preceding symptoms. They were the more common ones, and where there's been some change in treatment availability or treatment strategies. Abdominal pain can occur on its own, or usually it's actually in conjunction with severe constipation. So it's always important to consider that as a cause. The treatment tends to be around adequate analgesia and pain relief. In severe abdominal pain that also presents with sudden nausea, vomiting or distension, or even if this is incremental over 2 to 3 weeks, there is a condition known as pseudo-obstruction, and you can see it in this x-ray where all the bowel wall is quite enlarged or distended and with no clear transition point. So one of the causes of something like this that's considered is whether there's something blocking the bowel. This is what's called pseudo-obstruction, where there's no blockage, but through severe autonomic neuropathy or severe infiltration of the bowel due to the amyloid, the bowel becomes very distended and is not functioning properly. This can be quite a problem to treat. It tends to be relatively uncommon, but it requires usually hospitalisation, and on some occasion even complete bowel rest, which is the one condition where that may be suggested over sort of ongoing enteral feeds. with using intravenous TPN, means intravenous feeds for a short period of time. So one additional issue I'd like to address is the issue of patients being malnourished or weight loss associated with amyloidosis. It is important to address this early. There was a pivotal study out of the UK a number of years ago that showed that up to 60% of patients with AL amyloidosis at the time of diagnosis of their amyloid were already moderately or severely malnourished. And this was also found to be an important prognostic factor in terms of their long-term outcomes. Now, it's important that it's an issue that's identified early. Weight loss may not always travel together with malnutrition, so malnutrition markers need to be performed. Dietitian support is important. High caloric supplements can be used to improve caloric intake, but also any specific malnutrition needs. It's also important to then address the symptoms that have led to the avoidance of foods, such as gastric emptying problems or nausea, vomiting and the like. There may need to be alterations made in components of the diet depending on some of these other symptoms. And as a concluding factor to this, if the malnutrition is serious and hospitalisation is required, there is always a preference from a gastrointestinal perspective to do this with enteral feeds where possible. So in conclusion, I'd like to point out again that gastrointestinal symptoms are relatively common in amyloidosis patients. In the vast majority, this is indirect from the impact of disease itself or on other organs, but up to 7 or so to 10% of patients will have direct impact on the gastrointestinal organs themselves or the auxiliary structures that help them function properly. Management is aimed at identifying the cause if possible and also targeting to the most severe symptoms. There are new prokinetic agents and antibiotics used for small bowel bacterial overgrowth, but there are also existing treatments still available that can be very effective at adequate doses. And nutrition is very important to address early. So thank you for your time, and I'm looking forward to some questions.